Welcome to the deep dive. Today we're tackling a really critical topic, meningitis.
Yeah, it's a term you hear, and it often sounds quite scary.
It does. So we're going to unpack what's really happening based on our sources. Let's jump right in. Meningitis, basically it's about inflammation.
That's the core, yes.
Yeah.
But it's not just general swelling around the brain or spinal cord. It's very specific. Our source to point out it targets the meninges.
The meninges, right, those protective layers covering everything.
Exactly. Think of them as like protective sheets.
Like a security system. There's that tough outer layer,
Yep.
the durameter.
That's the one. But meningitis typically involves the two inner layers, the ones closer to the brain and spinal cord.
Ah, okay. And those are
They're called the arachnoid mater and the pia mater. They're more delicate.
arachnoid and pia.
And together, they're known as the leptomeninges. That's really the focus when we talk about meningitis. The inflammation happens there.
Leptomeninges, got it. And between those two layers, there's a space, right? The subarachnoid space.
Yes, and it's definitely not empty. It's filled with cerebrospinal fluid, CSF.
CSF. And that fluid has a job to do.
Oh, absolutely. It's crucial. It acts like a cushion, a shock absorber for the brain and spinal cord. Plus, it helps deliver nutrients and clear waste. It's constantly circulating.
A cushion and a nutrient delivery system. Okay, so if you looked at healthy CSF, what would you see? Our sources seem quite specific on this.
They are. Normally, it's surprisingly, clean. In a tiny sample, like a microliter, you'd find fewer than 5 white blood cells. Very few.
Fewer than 5. Wow.
Yeah, and mostly lymphocytes and monocytes. Only a tiny fraction are those first responder types, the PMNs, polymorphonuclear cells.
So usually pretty calm in there. Are there other things besides cells, protein, glucose?
Exactly. There's a bit of protein, usually between 15 and 50 milligrams per deciliter, and glucose, typically around 45 to 100 milligrams per deciliter.
Yeah.
And an interesting point our sources make is that the glucose level in CSF is normally about 2/3 of your blood glucose level. That comparison is important later.
Ah, okay, a useful benchmark. And the CSF, it's not static, right?
Yeah.
There's pressure, and it gets refreshed.
Precisely. There's a normal pressure, usually below 200 millimeters of water, and it's very dynamic. You only have about 150 millimeters in your body at once, but you actually produce around 500 millimeters a day.
500 millimeters, so most of it gets reabsorbed.
Exactly. It's constantly being made and absorbed. It's a very active system.
And getting things into this system, into the CSF, isn't easy because of the blood-brain barrier we hear so much about.
You got it. The blood-brain barrier is like extremely tight security. The cells lining the blood vessels in the brain, the endothelial cells, are packed together super tightly.
Like a zipper?
Kind of, yeah. Forming these tight junctions, it strictly controls what gets from the blood into the brain and CSF. It keeps most things out, maintaining a very stable environment.
Okay, so just to nail this down, meningitis is inflammation of those inner layers, leptomeninges.
Correct.
And it's not encephalitis, which is inflammation of the brain tissue itself.
Right, that's a key distinction. Though sometimes, as our sources mentioned, they can happen together. That's meningoencephalitis.
Meningoencephalitis. Okay, so if meningitis is inflammation of leptomeninges, what actually starts that fire? What triggers it?
Good question. Our sources list a few things. Sometimes it can be autoimmune diseases like lupus, where the body attacks itself.
Okay, the immune system getting confused.
Yeah. Or sometimes adverse reactions to medications, especially if they're put directly into the CSF, like with intrathecal therapy.
Right, but those aren't the most common causes, are they?
No, not at all. The overwhelming majority of cases, as the sources stress, are triggered by infection.
Infection, that makes sense.
Yeah.
Bacteria, viruses.
Exactly. Things like Neisseria meningitis bacteria or viruses like herpes simplex, those are the big players.
So how do these bugs, these pathogens, actually get to the meninges and the CSF? They have to cross those barriers.
Right. There are basically two main ways they can do it. The first is called direct spread.
Direct spread, how does that work?
That's when the pathogen gets into the skull or the spinal column somehow and then literally penetrates through the meninges into the CSF.
Like through a wound, or maybe through the nose.
It could be. Our sources mention things like entry via the skin or nose, but often it's associated with some kind of anatomical defect.
A defect, like something someone's born with.
Yeah, like spina bifida, a congenital defect. Or it could be acquired, like a skull fracture that causes a CSF leak. That creates an opening.
Ah, okay. An open door,
Yeah.
essentially. What's the other wrap?
The other major route is hematogenous spread.
Hematogenous. Sounds like blood.
Exactly. The pathogen gets into the bloodstream somewhere else in the body first.
And then it travels to the brain.
Yes, and then it has to figure out how to cross that really tough blood-brain barrier to get into the CSF.
Which we just said is really selective, so how do they manage that?
Well, they can be quite sneaky. Some pathogens have molecules on their surface that let them bind to receptors on those endothelial cells lining the blood vessels.
So they trick their way across.
Pretty much. Or they might exploit areas where the barrier is naturally a bit weaker or maybe damaged. The choroid plexus, for instance, where CSF is actually produced, can sometimes be a vulnerable spot.
Okay, so the pathogen makes it in either directly or via the blood. It's in the CSF. Now what?
Well, it doesn't just hang out, it starts multiplying, and that sets off alarms.
The immune system notices.
Yes. The few resident white blood cells there detect the intruder and start releasing chemical signals called cytokines.
Cytokines, like a distress call?
Exactly like a distress call. These cytokines recruit many more immune cells from the bloodstream to come into the CSF and fight the infection.
And that's why the white blood cell count shoots up in meningitis.
Precisely. Remember, we said normally it's less than 5 cells per microliter. In meningitis, it jumps way up. Generally, more than 5 is considered meningitis.
Okay.
But how high it jumps and which type of white blood cells dominate gives us big clues about the cause.
Ah, the different profiles. Our sources broke this down, didn't they?
They did. It's quite informative. For bacterial meningitis, the numbers are often really high, like over 100 cells per microliter, sometimes thousands, and usually more than 90% are those PMNs, the neutrophils.
The bacterial first responders.
Exactly. Now, for viral meningitis, the count is usually lower, maybe 10 to 1,000 cells, and the main cell type is different, usually over 50% lymphocytes and fewer PMNs, like less than 20%.
Interesting. What about fungal or TB meningitis?
Similar pattern with lymphocytes being key. Fungal meningitis typically shows 10 to 500 white cells, again, mostly lymphocytes, over 50%.
Okay.
And tuberculous meningitis, caused by TB bacteria, often has counts from 50 to 500, but with a really high percentage of lymphocytes, often over 80%.
So these different footprints help doctors narrow down the cause.
Absolutely. It's a critical piece of the diagnostic puzzle.
Now, this big immune response, all these cells rushing in, while it's needed to fight the infection, it causes problems itself, doesn't it?
It absolutely does. It's a double-edged sword. All those immune cells and the inflammation they cause lead to more fluid building up in that subarachnoid space.
Increasing the pressure.
Yes, the CSF pressure often goes above that 200 millimeter H2O threshold. And the immune cells, while fighting the germs, can also release substances that damage nearby tissues.
Collateral damage.
Sort of, yeah. Plus, the inflammation and the pathogens themselves use up glucose, so the CSF glucose level drops.
Below that 2/3 of blood glucose mark we talked about.
Often, yes. And finally, protein levels in the CSF go up, usually above 50 milli-GDL. This is partly due to the inflammatory cells and also because the blood-brain barrier becomes leakier during inflammation.
Okay, that makes sense. So let's talk about the specific culprits. Our sources group them into acute and chronic meningitis. Acute happens fast.
Yeah, acute meningitis comes on pretty quickly, often caused by bacteria or viruses.
And the specific bacteria depend on age.
Very much so. In newborns, the common ones are group B strep, E. coli, and Listeria monocytogenes.
Okay. And for kids and teens?
There, it's often Neisseria meningitis. That's the one people often associate with outbreaks, and also Streptococcus pneumonia.
And adults and the elderly.
Streptococcus pneumonia is still a big one, along with Listeria monocytogenes again, especially in older adults or those with weakened immune systems.
Our sources also mentioned a tick-borne one.
Right. Borrelia burgdorferi, which causes Lyme disease, can also cause bacterial meningitis.
Okay. Now for acute viral meningitis. What are the main viruses?
Enteroviruses are very common, especially one called Coxsackie virus. Herpes simplex virus is another major one. Then you have others like HIV, mumps virus, the chickenpox virus, varicella zoster, and lymphocytic choriomeningitis virus, though those are generally less frequent.
Okay, that covers acute. What about chronic meningitis? That develops more slowly.
Exactly, over weeks or months. And the causes are often different. Fungi become important here, like Cryptococcus or coccidioids, especially in people who are immunocompromised.
Oh, yeah. Okay.
Bacteria can still cause chronic forms, notably Mycobacterium tuberculosis, causing tubercular meningitis.
TB meningitis.
And even parasites. Our sources mention P. falciparum, the parasite that causes severe malaria, can sometimes lead to meningitis.
Wow. Quite a range of causes. So how would someone even know What are the classic symptoms that scream meningitis?
Well, there's a classic triad: severe headache, high fever, and neutral rigidity.
Neutral rigidity, it's stiff neck, right? Difficulty bending your head forward.
Exactly. That combination is a major red flag. But there can be other symptoms too.
Like sensitivity to light and sound, photophobia and phonophobia.
Yes, those are common too. Being really bothered by bright lights or loud noises.
And if the brain itself gets inflamed, the meningoencephalitis we mentioned.
Then you might see more neurological symptoms, things like confusion, altered mental state, maybe even seizures.
Okay, so if someone has these symptoms, what's the diagnostic process? What does the doctor do?
It starts with a physical exam. Doctors look for specific signs that suggest meningeal irritation.
Like those special tests, Kernig's and Brudzinski signs?
Exactly. Kernig's sign involves checking for back or hamstring pain when the straightened leg is raised while the hip is flexed.
Okay.
And Brudzinski's sign is when flexing the person's neck forward causes their hips and knees to automatically bend up. Both suggest the meninges are inflamed.
Interesting. But the definitive test is the lumbar puncture, the spinal tap.
Yes, that's usually crucial if meningitis is suspected. A needle is inserted carefully in the lower back, typically between the L3 and L4 vertebrae,
Yeah.
to collect a small amount of that cerebrospinal fluid from the subarachnoid space.
And they measure the pressure first.
Yes, they measure the opening pressure, and then the CSF sample goes to the lab for analysis.
And that analysis looks for the things we discussed: white blood cells, the types of cells, protein, glucose levels.
Absolutely. That core analysis is key.
Right.
But they can also run more specific tests on the CSF depending on what they suspect.
Like,
Like PCR tests to look for the DNA or RNA of specific viruses like HIV, enterovirus, or HSV, or bacteria like the one causing TB. If Lyme disease is suspected, they might do a Western blot test for antibodies. If malaria is a possibility, they'd examine a blood smear.
so they identify the cause, then what? How is it treated? It must depend heavily on what's causing it.
Totally. The treatment targets the specific underlying cause. For bacterial meningitis, it's critical to start treatment fast. Often, this involves giving steroids first
Steroids, why first?
to reduce the inflammation. Because when antibiotics start killing the bacteria can release substances that actually worsen inflammation initially. So steroids first, then antibiotics to kill the bacteria. Timing is really important.
Okay, that makes sense. And for the other types, viral, fungal.
Same principle, target the cause. Antiviral drugs for viral meningitis, antifungal drugs for fungal, antiparasitic drugs if it's a parasite. Getting the right treatment started quickly is vital.
And prevention. Can we prevent meningitis?
Yes, thankfully. Vaccination is a major tool. There are effective vaccines against some key causes like Neisseria meningitidis, mumps, and even disseminated TB.
So vaccines are really important.
Definitely. And in outbreak situations like with Neisseria meningitis in a household or dorm, close contacts who aren't vaccinated might be given prophylactic antibiotics, just preventatively, to stop them from getting sick.
Okay, good to know. So let's just quickly recap the main points from this deep dive. Meningitis is this inflammation of the leptomeninges, those inner protective layers around the brain and spinal cord.
Right, usually kicked off by something foreign getting in, often bacteria or viruses, either directly or through the blood.
And that triggers a big immune response, leading to inflammation, increased pressure, changes in the CSF, and those classic symptoms like headache, fever, stiff neck.
That sums it up well. It really highlights how crucial those meninges are and how the body's own defense, while necessary, can contribute to the danger of the condition.
Absolutely. This has been, well, a really fascinating look into meningitis. Considering how sophisticated that blood-brain barrier is, and yet how many different pathogens have found ways around it, it makes you think, doesn't it?
Yeah, what other defenses does the central nervous system have that we maybe don't fully understand yet?
Exactly. And how can we get better at treating these kinds of neuroinflammatory conditions in the future? Definitely some food for thought there. Thanks for exploring this with us today.